Good morning, and thank you so much for the invitation to present at the Global Humanitarian Forum. I have very fond memories of presenting rheumatic heart disease in the forum in 2011 in Geneva. I'm sorry I can't be with you in person, but again, really appreciate the invitation. I'm speaking today on the management of rheumatic heart disease in Africa. And I'm going to start with the statement from the South African Medical Research Council, where I now work, where we recognize the catastrophic and persistent consequences of colonization and apartheid. And this included the SAMRC's historical role and silence during that period. The important thing is that we commit our capacities and our resources to the continued promotion of justice and dignity in health research in South Africa, but also globally. And the important element about this is not only its importance in South Africa, but also on our continent and in the world, especially as we look at issues around justice, dignity, and equality at this particular moment in time. We understand that we've had this orchestrated assault on the research ecosystem of our country. It's targeted the most vulnerable in terms of HIV and TB, but it's also targeted science infrastructure, emerging researchers, and deliberately ending programs that are saving lives. And so I know that many of us are facing the same onslaught, especially in our continent. And so this actually represents a time where the most vulnerable are even more so being targeted by the global north. And we need to understand that and work towards it as we think about the treatment of something like rheumatic heart disease. One of the other things that is important is the understanding of policy. And so in 2018, we passed the Global Resolution on Rheumatic Fever and Rheumatic Heart Disease. And these policies serve as powerful tools for directing resources, action, and investment towards improving health outcomes and addressing health disparities. And if we look at the 7 key actions that went into this and to think about eradicating rheumatic heart disease, many of them were around treatment. So yes, there was establishing registers, but ensuring adequate supplies of PNG so that they can be used, improving access to reproductive health services, which also speaks to treatment, decentralizing diagnostic services, really important, the element of cardiac surgery, centers of excellence. So across the top, we're really talking about elements of management, whereas across the bottom, multi-sectoral programs and international relationships, we're talking perhaps a little bit more about the stakeholder realm of work. So this is about implementation research. It's about partnership, and the importance is impact to improve lives. So in this talk, I'm going to look at some of the areas about current status around treatment and management, focus on a few exemplars, and then highlight perhaps some future priorities in the last part. Looking at current status, I just want to acknowledge the people who have been working with me on this. Here's the team based, some at UCT and some at the MRC, but some also in other countries, Tanzania, and Kenya, because to understand where we are is actually quite a significant task. This also speaks to REACH, the team related to REACH, which is a scientific and technical organization helping in rheumatic heart disease. And I encourage you to join our website and look at some of the programs that we are able to present. And then finally, also our WHO Afro colleagues from the regional office. Many of them have moved into different positions now. Prof. Dango has retired, but this work could not have been done without this team. So a reminder for those of you in India, just like India is not one country, neither is Africa. And often we talk about what is the management of a particular condition in Africa as if it is one country. Africa is home to the greatest human genetic diversity in the world. It has an astounding amount of diversity in terms of languages, for example. There are 2,000 distinct ethno-linguistic groups, and nearly a third of the world's languages are spoken in Africa. We've got cultural, environmental differences. Nigeria alone has over 500 languages. I love the fact that it is home to 9,000 plant species in the Cape alone, and 69% of those plant species are not found anywhere else in the world. We also have this enormous social determinants of health issue with income status, which varies across the WHO Afro region, population density very different in the different countries. And then, of course, the Gini coefficient, where South Africa unfortunately leads as being one of the most unequal countries in the entire world. If we look at rheumatic heart disease, this is looking at DELIs. And again, if you look at the different continents, you see probably one of the most diversely different is that of Africa, with different DELIs in different parts of the continent. Again, reflected here, this is the sort of overarching prevalence, global burden of disease estimates, over 380,000 deaths globally, 50 million prevalence, but 96% of them are happening in low and middle income countries. You can see that is across our continent, as well as Asia and perhaps into Indonesia. If you look at the change in age standardized prevalence across the continent, is quite significant. And then the blue circles actually represent the number of prevalent cases. Again, an astounding burden on our continent and on the continent, sub-Asian continent. So when we often see some of the concepts related, for example, to rheumatic heart disease in Australasia, it's important to get a sense of burden in terms of the numbers that we're talking about compared to the numbers in Africa. So one of the things that we undertook together with our WHO colleagues from the Africa region was looking at rheumatic heart disease and rheumatic fever programs, looking at multiple reviews to get a sense of where we are at the moment. And we looked using the 5x5 framework that was authored by Rosemary Weiber some time back. This has just newly been revised. But this 5x5 framework looks at some of the baseline elements, some of the partnerships elements, and then in the top block, what we've talked about in terms of implementation research is primary, secondary, and tertiary management. And across the top would be the tertiary medical and surgical management. But it's important to understand, of course, that these feed into each other in a constant iterative process to be able to understand where we are. So if we summarize them in the publication across the bottom. Will take a little bit too long to go through each of them in detail, but these are the 5 Afro regions of the world. We looked at each of those domains, all 25 of them. And if we just look at this slide, there's some very key things. So in some regions of the world, there are far more information than in others. And that is very clear. In others, there's far more red than in others. If we look at the top left-hand corner, you can see there's either no information whatsoever or all the information is in red. So this is very sparse information without many details. And then in the bottom right, you'll see Namibia and South Africa as being one of those where there's a great deal of information and quite granular information at that. And we'll discuss that when we look at the exemplars. So this overarching review gave us the impression that there is so much more to be done in terms of rheumatic heart disease and rheumatic fever programs just across the WHO Afro region. And a particular concern is that was really affecting the issues of management even more so in our region, where we are dealing with the greatest burden of disease and really need to impact upon patients. So if we look at an example, I'm just going to use two examples of how we need to move things along. Again, quoting that wonderful African proverb, if you want to walk fast, walk alone, and if you want to walk far, walk together. And hopefully that is the approach that we're going to take as we move forward. So one of the big things is that we've been talking about a vaccine for a very long time. And we all know that when we looked at wanting and needing a vaccine in the global crisis that was COVID-19, the issue of inequality across the world in terms of vaccines was incredibly stark. That spoke not only to vaccine rollouts, but also vaccine R&D, and the populations that were being included when there were vaccine testing and trials being done. What was also very interesting was how vaccine information and information leading to vaccines were interpreted and being received. So a very good example was when the Omicron variant was announced by South African researchers. It was followed almost immediately within the hour with South Africa being put on the red list for travel, as opposed to being celebrated for sharing their significant research findings with the world as soon as it was confirmed. So this leads us to SAVAC. This is the Strep A Vaccine Global Consortium. It's being funded initially by Wellcome, and in the new iteration by Open Philanthropy and the Duke Foundation, as well as Wellcome, and is really focused on ensuring that when there is a Strep A vaccine, this will be available, this will be cost effective, it will be cost efficient for the countries and populations where it's most needed. And some of the work that's going into informing a vaccine is the SAVAC Sentinel sites, and importantly, 2 in the Northern Hemisphere, 2 in the Southern Hemisphere, but all represent, as we say, global South countries, the Gambia in Africa, Malawi, India, and then Fiji. And what they also represent is strongly endemic regions of the world, and going to inform how these vaccines will potentially be rolled out, and also how they will have local data or endemic country data as a part of the R&D process. We also understand much more what is going on in terms of the Strep A vaccine. This is another funded program called the I-SPY program. You can see in Africa the countries that are involved. And you can also see on the left the various reviews that have gone into the I-SPY program in Africa. This is led by Mark Engel, and the PI is Sharani Sriskandar from the UK, but again involving multiple endemic sites. Another very important program has been the GOAL study and the GOAL program. This led to a very important paper in terms of secondary antibiotic prophylaxis for latent rheumatic heart disease, led by Professor Emmy Okello and Professor Andrea Beaton. And this has also led to a series of research trials under the umbrella idea of the GOAL study. The ARC network is led by Andrea Beaton and funded by the Duke Foundation, and this is around improving ARF diagnoses. We understand that there is no diagnosis at the moment that is a molecular diagnosis or a point of care diagnosis All we have is the revised Jones criteria, which is at best an imperfect clinical decision tool rather than a definitive diagnosis. So to improve the diagnosis will be a significant opportunity for not only making the diagnosis early, instituting secondary prophylaxis, but then ultimately improving RHD outcomes globally. And so the ARC network is a team of global experts to identify biomarkers, and these will serve as a foundation for new ARF diagnostic tests. And you can see the ARC network really brings together the entire global community. I also want to address a very important network, which is the NCDI Poverty Network, with 4-phase theory of change, from a situational analysis and priority setting through to integration science with the delivery model design, then implementing Pen Plus in certain countries, and then hopefully national and even global scale up. These are the initial countries that are going to be involved. I think just on 11 or 12 of them in Africa, and then countries in Nepal or in the Indian subcontinent. And although this doesn't only speak to rheumatic heart disease, it also speaks to type 1 diabetes, to sickle cell anemia and congenital heart disease. These are areas, again, where global inequity has defined the way that these countries manage the disease and how the impact of patients living in those diseases reflect. So this is a really important network to be part of and to work with as we navigate the way that we work across the country to improve treatment and management strategies. One of the things with Pen Plus and some of the other strategies as well is the issue of task shifting and task sharing. And this is where we understand that to be able to deal with the massive burden of non-communicable diseases on our continent, we have to employ new techniques. And task shifting and sharing is certainly one of those that is relatively low cost, but high optimization for be able to deliver care. So in this particular picture, it's from a program in Tshwane in South Africa around hypertension diagnosis and care. You can see using a handheld device to be able to monitor hypertension, but you can see that this is also in the patient's home, and this represents a sea change in the way we deal with diseases that need community engagement to be able to improve outcomes. We also need to move into clinical trials. This is the Invictus clinical trial, where we looked at rivaroxaban in rheumatic heart disease associated atrial fibrillation. And it's so important to bear in mind that to date, trials looking at whether factor Xa inhibitors reduce stroke risk in patients with atrial fibrillation have not actually included patients with rheumatic heart disease as their inclusion criteria or their participant group. So excluding rheumatic heart disease from the opportunity to be involved in these studies. And so RHD patients have been treated with vitamin K antagonists, largely warfarin, but this required frequent blood sampling. It required different resources, and unfortunately meant that these patients were not monitored adequately and had significant complications associated with it. In the Remedy study, this was one of the core findings, not only that we needed different approach to anticoagulation, but also that the participants themselves asked for new studies to be launched so that they can review other methodologies. So this was a randomized trial in Africa, Asia and Latin America, and compared outcomes for those with atrial fibrillation, either taking VKA or taking rivaroxaban, but not having a mechanical valve. And you can see the VKA group had far less events. These were either stroke, systemic embolism, MI, or death, either from vascular or unknown causes, compared to rivaroxaban. This was statistically significant, and therefore the guidelines have had to remain constant. Rivaroxaban is therefore not indicated in patients with rheumatic heart disease in terms of atrial fibrillation. And this is really important because it impacts the lives of these participants. What we have found, though, on the other hand, is that one of the most important drivers for mortality in these patients are heart failure. This is also from that study led by our colleague Karthik, who is potentially in the audience, certainly from India. And what we could see was that in-hospital mortality is a major driver of global mortality in this cohort. So you can see in upper middle income countries still more than 25% in-hospital mortality related to heart failure. As much as a third of them died within 30 days, and much as 43% in lower middle income countries. Therefore, the 2023 World Heart Federation guidelines for the echocardiographic diagnosis of rheumatic heart disease has moved now to incorporate heart failure and the stages of heart failure into the guidelines. And so we see the framework for rheumatic heart disease development and progression going from a strep A infection there, a pharyngitis, but we increasingly understand the role of impetigo as well, then through to rheumatic fever, as I mentioned before, using the Jones criteria, then early rheumatic heart disease, no longer called latent, subclinical, so we use the term early now, and then moving on to for B will be stage mild, and not using the term definite, latent, or subclinical. This is then aligning with heart failure stage A and B, i.e. has got the possibility to go on to heart failure. Then when we look at advanced and end-stage rheumatic heart disease, that is WHF stage C and D. So this is where we would previously have called moderate or severe RHD. And then this is heart failure stage C and D, where you now have complications. And then, of course, this leads to death. So this is the new way of looking at the progression. And I think this is an important new graph. One of the other areas that we've always focused on is the issue of pregnancy and cardiac disease. If we look at this depiction, this is maternal outcomes as well as fetal outcomes. This is from the ROPAC register. You can see again Africa as well as India depicted on the slide. But this is not disaggregated into rheumatic heart disease. It's looking at all causes, but this is particularly looking at those that had a mechanical or a bioprosthetic valve. And so one can imagine, if you look at the global map, that excluding those in, I suppose, Europe and Americas, many of those on the African and sub-Asian continent would be those with rheumatic heart disease. So it reminds you that there's an impact both on maternal as well as on fetal outcomes. And then finally, going back to our rheumatic heart disease global register, 25 centers, 3,500 patients, and the vast majority of those outside of Yemen from either Africa or India. And here we can see again the significant disparity when we look just in these countries in terms of access to valvuloplasty and surgery, which is virtually not available in the low-income countries. This is a recent publication, both in Cardiology of the Young as well as in the World Journal for Pediatric and Cardiac Surgery, which I'll allude to in my earlier talk, where we look at pediatric cardiac surgeons per million population and pediatric cardiologists per million population. And you can see on our continent how dramatically short we fall of these two cadres of health workers. 1.25 per million in terms of surgeries, surgeons required, and we only have 0.04. And for cardiologists, 2 per million required, we only have 0.17. So if we're talking about management and for advanced rheumatic heart disease, the management really is around interventional or surgical treatment. We are very far short from that. We showed this diagram earlier, and where you saw under South Africa, largely green, red is around an advisory committee just going down. Laboratory services are not in every part of the country. Government engagement also obviously always can be improved upon, and then program evaluation also gets an orange box. But if we look at South Africa, even as we've mentioned before, South Africa is a two-tiered, highly unequal health system. We have a public sector which is state funded. It caters to the majority, about 73% of the population, whereas the public sector is largely funded through individual contributions to medical aid schemes or health insurance, and serves only 27% of the population. And I can imagine that for many of the people in the audience, you can attest to these and probably have a similar situation in your own cities or your own countries or your own regions. So this is a private hospital just a few kilometers from our home. You see the hybrid cath lab to the left, and you see the outpatient waiting area to your right. And this is one, a recent publication from a more rural setting in South Africa, where we identified that many parts of the country is in crisis mode. Not only is the hospital or the outpatients or the district hospital looking as depicted on the slide, but people also have to travel for miles and sometimes even for days just to get to their nearest health center. This is my hospital, Red Cross Children's Hospital, which is a public sector hospital, but you can see is very different. And so you also have the issue where you have a higher resource center in a lower resource setting. And again, I'm sure many of you can attest to this kind of scenario. So we have government clinics and hospitals where people pay for services that are based on income, and they do struggle with a persistent lack of funding, poor management of scarce resources, chronic drug short cutouts, stockouts, shortages of equipment and specialists, and ailing infrastructure. But on the other hand, this is far better than some of the rural setting structures. So you're also having to deal with patients coming from other parts of the country or other parts of the world where they are facing a very different structure. So this is where the Global Humanitarian Forum comes in, not only to support rural settings where you don't have infrastructure, but also to support higher resource centers of excellence within larger regions of the country or the province, so that they can also attest to many more people than they have at the moment. So if we look at RHD mortality, this is expressed per 100,000 population. This goes up to 2020. You see a dramatic and constant decrease in RHD mortality. And there may be questions as to where this comes from. So one of them is the work of the community health workers. A very important element is the fact that we overcame democracy in 1994, And there were many other elements that were put into place to deal with the diseases of the poor. One is primary healthcare, which improved dramatically since 1994, and generally an increase in our gross domestic product. We also have something called the National Health Insurance. This has not yet been fully implemented, but is underway. And then maternal, neonatal, and child health. And then finally, I think what is really important is the fact that we have surgery available to our population. So this is looking at prevalence of rheumatic heart disease in endocarditis and cardiac failure. And you can see quite a high mortality rate. But if you look at the mortality rate related to surgery, we know that this is an important way to go, and we know that there's more surgery available, and you can see this is very different. The surgery allows for a very low mortality rate of less than 3%. So if we go back to what we saw before. Across the top was the implementation science, across the bottom is partnerships. And if you look at differently, it's from bench to bedside to community, but now also to policy and public health. And that is where we talk about translational science, which is quite a critical thing. So if we think that in many years ago, sore throat was a death sentence, we are all working to try and change that and work for impact to improve lives. So Africa is a diverse continent with a differential burden of rheumatic heart disease. There are exemplars of multi-country collaboration that have led to or will lead to global impact. One of our strengths is significant long-standing partnerships that we have, as well as locally led research. Future priorities must include translational research, community and lived experience partnership, and then rapid expansion and advancement of skilled services such as cardiac surgery. And I believe that advocacy and activism remains key. So I'd like to thank you all again for the invitation, the kind attention, and wish all the delegates of the 15th Global Forum and the 6th Euro-Asian Forum very well in all your deliberations. Thank you so much, and all the best for the rest of the day.